Hello, and welcome to NCIHC On The Road. It is time to get this wonderful panel started. You are joining us today for Language and Healthcare Literacy, How to Speak and Write for a Diverse Patient Population. We're very excited today to have a wonderful panel of subject matter experts joining us today. First, we have Dr. David Scales. He is an internal medicine hospitalist and assistant professor of medicine at Weill Cornell Medicine and chief medical officer at Critica, an NGO focused on building scientific literacy. His research focuses on medical communication in clinical and online settings, including understanding how structural factors affect our information environments to allow misinformation to propagate and misconceptions to persist. Dr. Scales' work leverages qualitative and quantitative methods to address the problem of health-related misinformation, training infodemiologists to build COVID-19 vaccine confidence in online communities with community-oriented motivational interviewing. Dr. Scales received his medical degree and PhD from Yale University, where his sociology dissertation examined how the World Health Organization seeks to control the spread of disease across international borders. He completed a primary care internal medicine residency at Cambridge Health Alliance in Cambridge, Massachusetts. He also holds a certificate of medical interpretation in Levantine colloquial Arabic from UMass Amherst and has worked with refugees in the United States and throughout the Levant. Thank you so much, Dr. Scales, for joining us. Today, we also have Ms. Alison Caballero. She is an associate professor and director of the Center for Health Literacy at the University of Arkansas for Medical Sciences. She provides health literacy instruction for multidisciplinary health profession students and for health communicators across the country. She is driven by the center's mission to improve health by making health information easy to understand and use. As she oversees research, plain language material development, English and Spanish, community field testing, training, and organizational health literacy consulting. Alison completed a prevention fellowship with the U.S. Department of Health and Human Services and holds an undergraduate degree in health education and a master's degree in public health from UAMS. She has been a certified healthcare education specialist for 25 years. And joining us today, we also have Prado Antolino. She is a language service manager at Moffitt Cancer Center in Tampa, Florida. She holds a bachelor's degree in English philology from the Universidad Complutense de Madrid in Madrid, Spain, where she was born and raised. Additionally, Prado holds a master's degree in translation and applied linguistics from Kent State University in Kent, Ohio. Prado has a double certification in translation from the American Translators Association and in medical interpreting from the National Board for the Certification of Medical Interpreters. She has also an ATA certification exam grader in English into Spanish pair for over 10 years. In her role as manager, Prado advises on language access policy, application within the Cancer Center, devises strategies to encourage equitable language access throughout the institution, provides education and awareness on how to work effectively with translators and interpreters, and devises and administers the bilingual proficiency assessment program. In her free time, and in no particular order, she loves to read, run, spend time with family and friends, and travel. And I am Gabriela Siebach, today's moderator for this panel. So let's go ahead and get started and let's hear from our experts. We have a wonderful panel. Welcome to all three of you. Why don't we start with you telling us a little bit about your involvement or maybe your organization's involvement in health literacy for culturally and linguistically diverse populations. Why don't we start with you, Alison?
Sure. Well, thank you so much to all of you for the invitation to be here. I am excited to share some of the work that we're doing, and I'm really excited to learn from Prado and from Dr. Scales and from all of your comments and thoughts in the chat. I think this is going to be a rich 90 minutes, and I'm excited about it. So I am with the University of Arkansas for Medical Sciences, the Center for Health Literacy. So we are just 100% focused in our shop on making health information easy for everyone to understand. And for us, equity is a big part of that. Our work within our center, as Gabriela mentioned, has to do with training students who will be the future healthcare professionals, but also working on patient education materials. And I can speak to that later. That's a relatively new body of work for us. And doing training with active healthcare providers, not just within our health system, but beyond. Our interest in equity has been around because there's such an important connection between health literacy and health equity and special populations. But we really just launched our Spanish language efforts about 4 years ago. So we're still relatively new in this space, and thus I'm very excited to be here and share what we have been doing, and again, hope to learn a lot from you all as well.
As you said, I work at Moffitt Cancer Center. We are a hospital, a cancer center, and a research institute designated by the NCI. And in my work in language services, I work with interpreters and translators. And I think it's very difficult to be a translator in the medical field and not want to help our patients achieve some level of health literacy, even if that's not the area of expertise per se. You know, I rub elbows with a lot of departments within the hospital. We work with our researchers as well, interventional studies, population studies. So we do a lot of informed consent and tons of patient education materials. And our nursing development department, I think, is probably the one that takes the lead within the hospital in health literacy per se, not only by applying, you know, those principles of plain language to the materials that they develop, but also by training nurses specifically on both learner verification techniques and teach back. And so we work very, very closely with them, also in trying to teach them or to collaborate with them so that they develop materials with translation in mind. There's, you know, many branches to this, so I'm gonna leave it at that, so Dr. Scales can introduce himself.
Thank you. And it's wonderful to see, because I think for many of us today here, that collaboration and that working with plain language and, you know, that linguist perspective, the translator and the interpreter, is going to be very interesting on this panel. Now, Dave, why don't you tell us a little bit from your angle? What is your role in health literacy? I don't think it's every day that we see somebody with a medical degree who also has interest in interpreting and a certificate in interpretation.
Yeah, no, thank you, Gabriela, and it's wonderful to be here, and it's an honor to kind of share the screen with Prado and Alison as well. The work that I do kind of has sprung from a longstanding interest in communication, and the fact that, frankly, a lot of doctors aren't necessarily so great at it, because relatively speaking, relative to all the other stuff we have to learn in medical school, all the stuff that we learn is so focused on learning the science that we don't always really learn how to communicate. So the work that I do, kind of both in my academic job at Weill Cornell and also the work that I do with Critica, which is an NGO, is focused kind of on both sides of the spectrum, in the sense of, like, we work with professional organizations to try to train them to consider where patients are coming from and how to better communicate and meet patients where they're at. And on the other side, we are working with infodemiologists who come from communities that they're communicating with, not just to kind of communicate science, but also to help essentially interpret in some way, if you will, kind of like how to understand the science within the context of community identity, community values. So it's a little bit, it's not just kind of a communicator, but it's a little bit trying to be a little bit of a step beyond of also kind of an interpreter. So we've got a couple of projects working in these different directions.
It's very interesting that you mentioned that, and all of you mentioned the wonderful role of health literacy, which of course I asked about. But I think, you know, something that most of the people, we have over 150 people on the call right now listening to you, they're probably wondering, what's the current state of health literacy? Do any of you have any data that you could share with us in terms of what the current state of health literacy is in the US specifically?
Do you mind if I just offer up some definitions for health literacy actually first? Is that okay?
That would be fantastic. Thank you.
Okay. And I think there are definitely many definitions out there, and I don't want to suggest that one is right and the others are wrong. But it's my experience that very often when I tell someone I work in health literacy, they'll say, oh, so you're teaching people how to take better care of themselves. You're teaching people about healthy lifestyles. And I'll say, well, that's health education, right? The art and science of planning what to teach and teaching it, that's health education. And they'll say, oh, well, then when you say health literacy, then you must be talking about helping out people who can't read with health information. And I'll say, yes, but that's part of it. And then they'll say, no, what you mean is that health literacy is the degree of a person's knowledge about a specific health topic. So if they know all about brushing teeth and flossing and oral health care, then they have good oral health literacy. And I'll say, well, that's not exactly how we define it. And so I just want to throw a definition out there. And I take this from the Healthy People 2030, which are the nation's health objectives. And it is the degree, there's two definitions. So the first is around personal health literacy. And so they define that loosely as the degree to which a person has the ability to find health information, really process it and understand it, and then use it to improve their health or navigate the healthcare system, right? So it's kind of a mixed bag of skills, and I can go into more of that later. But then organizational health literacy is how well do we as organizations equitably enable people to do those things, to find, understand, and use health information in a way that helps promote health for themselves or the people that they care about. So it's kind of this complex set of skills. So I just wanted to throw that out there to start us off.
That's a great way to get started. What are we even talking about today, right? So what are your thoughts, Dave? Do you agree with the definitions? What angle are you most familiar with? Is it the individual health literacy or organizational?
First, thanks, Alison. I think it's very helpful to have those definitions. And even I love how you dispelled kind of various different understandings of what different people might assume health literacy to be, because I think there's a lot of misunderstandings about that, but I think it's pretty well defined by different people. And I know there's kind of various different definitions in the literature. I would say kind of the work that we do is focused at these two levels, in the sense that it's even trying to raise awareness among, I think there's a lot of organizations that kind of recognize that health literacy is an issue, but I think make the assumption that I know this happens in medicine, that simply just providing more information kind of solves that problem. And this is a little bit of what we call kind of a knowledge deficit approach, where if like someone doesn't understand something, then let's just provide more information and we have checked the box and there we go. And a lot of informed consent forms kind of work this way. A lot of informed consent for research. So a lot of what we do is even just trying to raise awareness within kind of organizations and on the service provider side of things, that there's a lot more to it than that. And we do some other work too, kind of on the personal front, but I can come back to that. But I think that's a good starter point, I would say.
Absolutely. Now, Prado, I saw you smiling as Dave was telling us a little bit about trying to put more content into documents that you probably translate. So tell us a little bit from your point of view, what you've seen or come across when it comes to health literacy and I'm assuming organizational attempts at achieving it.
You know, with the side about informed consent, for research, for example, you know, you have a 30-page document filled with these very highly technical concepts. And although the recommendations are to write for a eighth grade level, let's be honest, it's not happening. It's really not happening. And it's not only the technical concepts, it's also sometimes how disorganized the content is. So it's very difficult to follow along. And as a translator, you know, we have a degree of education and we work with words all day long, and we think we know a lot of medicine by osmosis as well. And then you sit down to translate and you can't make, you know, heads or tails or some of the sentences. There's lots of terminology inconsistencies, syntactic inconsistencies, and so on. Although there's a very templated language even within the informed consent. So you saw that smile because I think that's probably one of the hardest types of documents to translate as a translator in a healthcare institution. And it causes a lot of like moral distress, and I hope I'm using this phrase correctly, because you figure if I am having this much trouble translating content that I'm familiarized with, what is the patient on the other side doing, and what are they signing really? We could go into informed consent. We probably should do a whole other session about what informed consent actually represent. So anyway, I don't know if that answers your question, but that's why you saw me
I think
smile.
it does. And I think you brought us back to the very important topic of, okay, let's go back to what the current state of health literacy is, right? So you took us from the organizational and then back to the individual and their health literacy. So Alison, I think you're probably the one that has some of that data for us that you might be able to share. Tell us, is there anything out there?
Sure, there is, but it's a bit dated. So there is the National Assessment of Adult Literacy from 2003. So that is 20 years old. But in that assessment, you know, it's a larger assessment of literacy on a broader scale, but it's got some health literacy components to it. So that is the best measure that we currently know of that really gets at health literacy. And it looked at several of the different skills. So there's some obviously reading skills involved. There's some using math. We all know we ask people to think about quite a lot of numbers and how those numbers relate to each other as we describe health information. So it looked at several of those things. And basically the NAL told us that only about 12 out of 100 adults in the US has proficient health literacy skills. So remember back to that definition, you know, finding the health information, reading it, understanding it, processing it, internalizing it, applying it to their own lives. So, excuse me, quite a low number. And when, you know, we're talking about diverse populations, and when we look at racial and ethnic categories other than white, the numbers are even fewer. And at least in 2003, the Hispanic population that was assessed at that time had more challenges with health literacy than any of the other racial and ethnic groups. And we know that here in Arkansas, we definitely have a growing Hispanic population. And for individuals who don't have English as their first language, in most places across the country, they are functioning in a predominantly English-speaking health system, right? So despite the fact that we have this growing population and our university and system are making tremendous efforts, as I know many are, to make information equitably available, we're not 100% there yet. And all of the language spoken and written and in audiovisual format, the whole shebang is not available in all the languages that someone might need it. So if you are not, you know, if you don't have English as your first language and you're functioning in that system, there have to be some even greater challenges.
Excellent. Now, Prado, when you were responding to the previous question and you mentioned how as you translate, sometimes you're concerned that the information will not be accessible to the patient because it's not even fully accessible to you. Could you share a little bit more about maybe your own patient demographic and what are some of the things that cause those concerns?
So our biggest demographic group in the Tampa Bay area is the Spanish speakers. So our solutions within the hospital for Spanish speakers are probably much stronger than for other populations. Clearly, we provide interpreter services to any patient who speaks any language. We had a case this morning of a patient who speaks Quiche. So here I am. If there's anybody out there who can assist us, contact us offline, contact me offline. And so a lot of the translation work we do for the Spanish speaking patients and probably Vietnamese, Arabic, Chinese, and Portuguese are the other 4 languages after. I forgot what your question was. Some of the challenges that, well, so, I mean, truly, sometimes when I approach my work, I'm also thinking of myself as a patient. We are all consumers of healthcare, right? And I have to admit that when I go to the doctor, even for some more complex things, I'm kind of like, oh my gosh, I am like perhaps our patients. I just got thrown all this information and I'm not totally quite sure what to do with it. But then I can go home and get on the internet and ask my husband and talk to my friends and talk to the doctors around me and get there. I don't think a lot of our demographics necessarily have that opportunity or advantage at all. And so when you're looking at documents that are disorganized, that are using inconsistent terminology, we're calling up the same medication by 3 different names. These are the kinds of things that I'm thinking, what are we doing with this document? And sometimes I don't have the privilege to speak to the author and try to do something about it. We don't have a Center for Health Literacy. You know, I would love to have an Alison Caballero around me. And so you still have to translate what's on the page. And so that's what I meant, that there's not a whole lot of recourse as a translator sometimes to try to make it better. You can organize the sentence better, and your Spanish-speaking patients might get a better product, but that's not necessarily the point either, right?
Mm-hmm. So now, Dave, you were mentioning a little bit about your work and working with organizations and everything. Are there any kinds of data or stats that you're looking at or that you're sharing, or what does health literacy out there in the US look like, and what is it that you're trying to approach with the organizations to improve it?
So I'm glad you asked that, Gabriela, because the data that Alison presented, putting that a little bit in context, it is dated, but I think my concern would be, and Alison, please correct me if you're aware of some data, is there's a lot of concern about how the structure of how information flows has affected people's health literacy, in the sense that I think there's a certain, just to give an example of the statistics that Alison quoted of 12 out of 100, which is really low. It would be interesting if in that survey, they asked people how many people thought that they had a sufficient level of health literacy to be able to make health decisions. And I think one of the things that we notice in the work that we do, mostly kind of in the digital contexts with our infodemiologists, is that there's a lot of confidence that people have a high degree of not just health, but scientific literacy, ability to read scientific papers and interpret them so that they can actually understand kind of emerging science and make health decisions based on things that are coming out in medical journals, which frankly are even hard for me to interpret. And I think that there's a sense that that people would assess their level of health literacy and science literacy is very high. And my concern with that is I would actually be concerned that health literacy, as defined as Alison defined it, I wonder if it's actually even possibly decreased since 2003. And so we have this mismatch and this yawning gap between kind of what the actual level of health literacy is versus how people perceive their own level of health literacy. And I think that's a major problem that is somewhat precipitated by information flows. Like, I think we when it comes to certain very common things like flushing a toilet or something like that, like we think we know the answer to that. We have this perception of knowledge because it's at our fingertips. We could just Google that, right? But if you ask someone to explain how a toilet flushes, like, you suddenly realize where the limits of your own understanding.
Right. Thank you so much for that. So circling back to you, Alison, because you shared this meaningful data, and I think something that Dave kind of introduced as well, I think we're all probably wondering, since you have that research from 2003, is there any correlation or relation between health literacy and literacy?
So I want to touch really quickly on something that you said, Dr. Scales, and I agree. I think that it's probably, if it were to be reassessed right now, I think we would see things a little bit maybe worse, because we have a more diverse population than we had in 2003. And because of exactly what you said, information is at our fingertips and we're just overrun with it. There's no shortage of information. So I think all of those things make things more complicated. We've also introduced new navigational requirements, if you will, for patients, right? Or even public health program recipients. Doesn't have to be limited to healthcare here. In digital health, because everybody wants their patients to use the patient portal and to schedule those appointments online and to confirm those appointments via text and to fill out that, pre-registration survey online before they come in, right? And we all know, I cringe every time I hear someone say, oh, well, let's just do this digitally because everybody has a smartphone. And I just cringe a little bit. I know I live in a rural state where we might have some additional challenges, but folks don't all have smartphones or broadband service at home or the digital literacy skills to be able to use those things. So to your point, in terms of how are people acting out their health literacy skills, I don't think we've measured that in today's landscape of where information is and that flow. So, but that's not what you asked. You asked about literacy and functional literacy. So definitely connected. Think about how much information, health information people get that comes in written form. Well, if I have functional literacy skills, challenges reading, challenges processing what I've read, right? So there's a difference, and I'm not a linguistics expert. I think Prado could jump in here, but there's the being able to read and say aloud the words on the page but then there's also the ability to really make meaning of those and put those concepts together in a really practical and useful way. And certainly when you have challenge with any of those basic literacy skills, those functional literacy skills, that's going to spill over into your ability to be an effective consumer of health information, because so much of it is written. Every 2 weeks, we get to stand before all of our new clinical personnel at our hospital and explain to them why they should care so much about patient education. And one of the things that we tell them is that those written papers that you send home with people, those instructions, are critically important. In healthcare, when people are in your presence and they're listening to verbal instruction, and I'm not suggesting we shouldn't do verbal instruction, we absolutely should, but there are so many learning barriers, right? I mean, and put yourself in the perspective, in the seat of that patient or that caregiver, that mom or that child of a parent, an aging parent. We're tired, we're stressed out, we don't feel well, we're perhaps in pain, perhaps there's some sedation going on. There's a lot of challenges. So that written material becomes all people have when they get home. And so it's really critical that be written in a way that everyone can understand and benefit from. And certainly that functional health literacy skill set could get in the way of that.
Absolutely. So now we're talking about functional literacy, and we've also introduced the topic of how information is being communicated, right? So, Prado, because you work at a hospital, you are managing a lot of the information that gets translated to reach the population that we're specifically talking about, which is a population that's culturally and linguistically diverse. What are some of the things that you are doing in terms of how information is being put out there?
You know, when we were talking about our individual health literacy and organizational, I was thinking that perhaps it is the organizational health literacy, the piece that we are, missing over here, if I can be a little bit self-critical. As I mentioned, the patient education department does incredible work, and I believe my colleagues might be on the call as well. Having a seat at the table, language services it's under the umbrella of enterprise equity within Moffitt. And the vice president of the department has done an incredible job of really trying to invite interpreters and translators to the table. So when there's organizational initiatives, we can sit at the table and start teaching or educating others on considering diverse populations before we do anything within the hospital. So that could be, navigational signage. That is a whole other topic we could talk about, I'm pretty sure. That could be the information that we're giving and how. And I have done, a fair amount of in-services. So I do sometimes a lot of one-on-one education, and in working with other departments, where we work with the marketing department, even with the patient education department, nutrition documents, for example, come to mind. When we are teaching populations about nutrition, it cannot be the sort of American diet, because when we translate those documents into Vietnamese or Chinese, or these populations are not necessarily recognizing these foods. So you might be proposing to the patient to follow up a low-fat diet, but a low-fat diet where? With the foods that surround you where? And so it's really a step beyond just translation. I mean, we're talking about translation very loosely here, but is it more of a cultural adaptation to the population that you're working with? And I feel like there's still a lot of work to do institutionally to get there.
Okay, so so we're talking about the means of communication, which is a topic that Dr. Skills introduced. We've added this functional literacy and the role that it plays. And now we're also adding cultural aspects that affect people's ability to comprehend the information. Dr. Skills, what are your thoughts?
These are great points. I would add to this that, and this is something that I'm sure Prado knows a lot more about than I do, but one of the challenges that I've seen that we run into is sometimes when we're trying to do things as providers, that is trying to explain certain specific concepts, and we run into challenges because there's someone brought this up in the chat of kind of differences in registers. In the sense that, like, one example I always like to give is just the confusion in Arabic that can come from talking about antibiotics. The word for antibiotic is mudad al-haywi in Arabic. But the challenge of that is that's a word that most people don't really understand and don't use in everyday language. that's the word. If you go to Google Translate and it translates, it will translate directly. So any written material will have that. But the word that is used in common speech, at least in the Levant, is mudad al-iltihab, which literally means anti-inflammatory. So there's a certain kind of almost conceptual problem that we have to separate. That like when I'm working with refugees, I have to spend a lot of time kind of like conceptually separating kind of antibiotic versus anti-inflammatory. So I'm doing a certain amount of health education, even as I'm just trying to kind of like, you know, even if I want to give someone directions to go home and take anti-inflammatories for their knee pain, I have to clarify that I do not mean antibiotics, right? This is one of that kind of like, you know, same word, many meanings problem is something that comes up very frequently as we're moving between kind of these different registers of like medical language versus, you know, more everyday language, especially as we're kind of like moving between kind of different, you know, languages specifically.
That
Absolutely.
is, if I can say something very quick, that is a great point, and I think that's where interpreters can actually help. I mean, obviously you have the background, the sensitivity, the awareness to make it probably work very well with your patients. But you know, in healthcare today, in this very, you know, we're rushing through, not rushing through, that sounds terrible, but you know, physicians have a lot of pressures, and on top of it, there's language barriers, right? And I feel like that's where interpreters, when really considered part of the team, can become really the partners for the physicians if that relationship can happen. And I know there's many remote interpreters out there listening to us. A lot of the perhaps scenarios that I might talk about are very relevant to my workplace. They might not replicate in other workplaces. I'm fully aware of that. But I feel like when you have staff interpreters in a hospital setting like this one, that kind of partnership is truly possible. And by considering the interpreter sort of the cultural advocate and the partner in this, some of these issues can be at least minimized. Perhaps not, they might not disappear, they cannot be removed, but a lot of deeper work can certainly be done. So that, I had no idea about that in Arabic. That's a challenge. That's incredible. No idea.
Wonderful. So I want to come back to you, Alison, really quickly, because you were talking about the medium of providing the information and how appropriate it is or not. We actually have a question that came in from one of our participants about whether or not we have explored audio recordings for discharge instructions, and that as a means of being able to provide health information, kind of going back to how you mentioned the spoken oral information, because again, the functional literacy may be different. And are there any other issues in using strategies such as that in terms of health literacy that might arise?
Yeah, that's a great question. Thanks for raising that. So there are, you know, when you think about your patients, everyone likes to learn differently, right? And so if you work in a facility that's accredited by the Joint Commission says you need to be assessing, you need to do a learning assessment with all of your patients. And part of that learning assessment is figuring out how your patient prefers to learn, how they learn best. And maybe that is something different than spoken communication. Maybe they want the print, maybe they don't do print for various reasons, and they would benefit from a more audiovisual approach to the education. Maybe they need a caregiver in the room to hear things with them because they have some serious challenges, cognitive or otherwise, and they need a partner to help them hear all of that. So I think audiovisual supports are great teaching tools. Any of that, the written, the audiovisual, they're all tools, right? None of it ever replaces that verbal communication that comes from staff. But it's also, if we're being practical, it's also very expensive. So a lot of your patient education vendors have packages that include both print materials and audiovisual materials. And so if you do have a package like that, and we're learning with our work in patient ed at the hospital that many clinical staff are not aware of all the patient education resources that your facility might already have a license to. So I would take that as a to-do from today for sure. Ask, find out, and you might have to ask different departments. If you have a patient education department, they would know, but perhaps you might need to check with, you know, language and interpreting services. They might know. You might need to check with communications, but you might have access to some of those things already. When it comes to custom content that your hospital or public health or other system creates, it's very labor intensive to create new content. If it's done well, then it involves, you know, clinical experts to ensure that there is clinical accuracy with every word that's on that page or in that video. Hopefully you have access to a plain language expert who can help you ensure that all that content is optimally readable, understandable, actionable. But then that's just paper, right? So you can imagine the other hands, you know, digital designers and folks that need to be involved when you're talking about producing audiovisual material. The challenge then is not just the initial production of such things, it's the upkeep, right? So when Dr. Scales comes back to you in 3 months and says, oh, remember that handout that we made about this, you know, thing called COVID, you know, there's some things, few little things that changed and we need to update that. Well, if you turn that content into a video that was costly to produce the first time, there's an ongoing cost for upkeep. So I think they're beneficial, but I just want people to think through the challenges and not jump to, we should have audiovisual for everything. You might have to prioritize.
Dr. Scales?
Yeah, Alison, I think that's a great point. I just wanted to add on to that because I think seeing interpretation, not just as an interpretation issue, or kind of when we're talking about some of these issues as a broader kind of health education and health literacy issue, I think is really important because some of the experiences that we've had at New York Presbyterian, for example, where I work in Chinatown, and easily half of my patient population on any given week speaks various different dialects of Chinese. And we used to have in-person interpreters. But one of the things that's happened, kind of, you know, due to the pandemic and due to various kind of downsizing and budget cuts, is it's now gone from in-person interpreters to virtual interpreters or telephone interpreters. And, you know, while that checks the interpretation box, one of the things that I would say is it really has left a yawning gap when we start thinking about some of these other aspects of kind of just health education and health literacy that I think we're leaving a lot on the table. And I think our patients might be worse off because of it.
Very interesting. You said, I think our patients might be worse off because of it. So let's talk a little bit about patient outcomes and health literacy. Like, why are we even holding this panel? Why is health literacy even a topic that we're discussing? Can you take that on first, Dr. Scales?
You know, this isn't something that I know all of the outcomes data with, in part because I think, you know, as a researcher, one of the things that I see is it's a very complicated chain of causality. And so it's very difficult to do kind of the types of studies that we like to do of like randomized, double-blind, placebo-controlled trials that really give us like the hardest possible data to say this intervention leads to this outcome. And so we have to look at other types of data, and it's usually things like natural experiments that are looking at kind of, you know, what is the difference in patient outcomes before something was implemented and then after something was implemented. And you know, I will say this isn't necessarily something that I follow the data really closely on, but the data that I have seen, at least, it tends to show that, and there's been a lot of work looking at this with regard to kind of the question of readmissions after a month, because that's often tied to payments. And generally, like, you know, I would say in general, and please correct me if I'm wrong, Alison or Prado, for those of you that might know more, but, you know, as you can improve kind of, you know, interpretation services, right? And I know it specifically with regard to interpretation and not just even necessarily health literacy, then there tends to be improvements in care that manifest in reductions in readmission, things like more adherence to medication regimens, things like that. And again, I think these studies are really hard to do. And so the evidence isn't as strong as we'd like, but the trend seems to be in the direction of what you would expect of if you provide high quality services that meet people's communication needs, then there is actually usually a response in terms of outcomes. It's often just hard to measure.
Alison, do you have any information in regards to the correlation between health literacy and patient outcomes?
Yes, and I can't quote anything specifically, but there is a study, if you just Google health literacy in Berkman, Berkman, there is a paper that we read and reference often that draws some associations between individual health literacy status and several important health outcomes, including mortality in certain populations. So there's definitely data to support that there, you know, it's a patient safety issue. When we talk with healthcare administrators, we often speak in terms of the quadruple aim. So for those who are not familiar with that, quadruple aim, it used to be triple aim. Triple aim was a better experience for our patients, better outcomes for our patients, all while containing healthcare costs. And the fourth aim that's been added to that is provider satisfaction, because we recognize that we can't manage those other three efforts at the expense of provider satisfaction. So healthcare administrators everywhere are dealing with how do we get this quadruple aim, and particularly the cost piece. The way we get paid for healthcare is changing. It's not fee for service as much anymore as it is, value-based reimbursement. And so there is a lot of effort and incentivizing going on with regard to keeping patients healthy and out of the hospital and not coming back after they've already had a visit, not using the emergency department when they don't need to. And so there are correlations between health literacy and every one of those things. If you just think about, take patient experience, for example. If you're part of a health system that uses the HCAHPS patient experience survey, and many of you do, there are numerous questions about communication on that survey. How well did your providers explain things in a way that you could understand? Did someone tell you about a new medication and what it was for and the side effects to watch out for and how to use it? Did you have adequate information to take care of yourself once you got home? Several questions related to understanding. And so no matter what language we're talking about, that connection between health literacy and real priorities of health systems is real.
So Dr. Scales and Prado, you both introduced the topic from a couple of different angles, and some of our participants are interested in exploring it a little bit deeper. So Prado, you mentioned Quiche and it being an indigenous language and it kind of showing up magically in your needs recently. And then Dr. Scales, you talked about how in some languages there are concepts that may not exist, or there are ways of referencing two completely different concepts with the same word that could cause confusion. Can we explore for just a second, some of these indigenous languages, or even languages that just have terminology or lack healthcare terminology, that what problems could they cause? Prado, since you haven't spoken for a while, why don't we let you talk a little bit more about maybe your approach to indigenous languages, and then maybe Dr. Prado, you can add a little bit based on the example you provided before.
I have worked on MOFIT for 20 years. This year is going to be my 20th year here. And in 20 years, I've encountered 3 Mayan language speaking patients. That's it. With 2 of them, we were able to provide interpreters directly from a very well-known, I guess I can't do public, advertising, but we were able to provide services beautifully. And with the Quiche patient who came this morning, the Quiche speaking patient coming this morning, it was sort of I don't even know if I should talk about it, in public. There's so many people, because it's probably a lot of bad practices going around. But it was around informed consent, and the patient spoke a little bit of Spanish. We were not able to get a telephone interpreter in Quiche because with either one of our providers, we have a couple of redundant services for OPI, and there's no video interpreters for Quiche. And we were not able to get those interpreters right on time because the ones available were on other cases. I mean, this is sort of I assume, unavailability, really. There's just not a lot of Quiche interpreters going around. And so there was a Spanish interpreter trying to assist with a little bit of Spanish. It was really not. And so eventually I talked to the surgeon, and we were able to postpone the appointment to try and then work with our providers, with our OPI video and agencies to bring a Quiche interpreter, or at least connect with one via video a little bit later on. But at the time, even the Spanish interpreter was not really able. And at this point, the interpreter, who is incredibly well trained and knows exactly what the boundaries are, was trying to partner with the surgeon to try and gather basic information. And it just wasn't even happening at that level. Her Spanish was so basic. And so at the same time, I'm getting pressure from the surgeon because this patient needs care. And so what do you do at that point? You know, I don't dispense blessings to consent patients who don't understand what you're about to do to them. It's a very complex issue, and I don't know enough about indigenous languages to be even giving any information to anybody. But I can speak from a manager perspective how complicated it can be, especially when the patient presents and the language indicator was wrong. I mean, it was kind of a systems problem. So we weren't ready. We're not ready. So that was the experience literally 3 hours ago.
Wow. Thank you for sharing that. I think it can be challenging to share challenges, but I'm sure there's people like the participant that submitted that question on the call today that share in that problem. Now, Dave, you mentioned earlier the challenge with Arabic, and I know that's one of the challenges with many indigenous languages as well. It's not, there are things that linguistically do not exist, concepts that there's no linguistic equivalent for, concepts that themselves don't exist. So how do you go about explaining them? Could you share a little bit more from your experience?
Sure. And thanks. And I appreciate you calling me Dave. I like to emphasize, please, everyone on the panel, please feel free to call me Dave. The way that I think about this is in general, like doctors are highly specialized experts in certain things. They're not necessarily, they and can't be experts in everything, right? And that's where we often need other people on the care team to kind of assist us in different things. And I remember when I worked at Cambridge Health Alliance, which is where I met Vanessa Costa, who's also on the call. I learned a lot from our interpreters because there were certain things that kind of understanding what words might have different contexts, even if we directly translate them. In some examples, for example, and I'm not an expert in this area, I'm just essentially repeating what I have heard from other interpreters, are things like the word a hospice. And so sometimes it might not always be a good idea to translate that word, interpret that word directly. Then because that in certain cultures that carries different meanings and contexts. And that brings up a little bit of kind of the larger point that I think it's not just a question of kind of the cultural know-how to know what words to interpret, right? But words are only one aspect of the language. But how we speak is a very important kind of cultural aspect of our language. I work in New York. If we say what we think and we say it really directly, right? That can sometimes be a really hard thing to interpret. And like in Arabic, for example, it is rude to speak so directly, especially about very sensitive topics. So yes, words like cancer exist in Arabic. Or words for sexual body parts. Yes, they exist, but they're usually not talked about directly. Sexual body parts are usually referred to with euphemisms like down there, things like that, right? Or something like cancer is usually referred to as like a swelling or a growth, right? And these are things that you really have to know the language really well to know what might be things that actually alienate your patient if you actually use those terms directly. And I say this because, just to give an example, right? And I'm speaking to professions that, just to give one example, in my health system, I spend a lot of time actually teaching and training people that interpretation and translation are not the same thing. And so that we're not calling translators, we're calling interpreters. And even that small distinction is really important, because I often find that when we're working with a very diverse patient populations, that kind of getting our providers to understand these kind of factors and how important they are in the care process is it's a long process. It takes a long time, but it's a really important one to kind of meeting the communication needs of our patients.
Thank you for that. Alison, I'm wondering, because we've talked about, and you shared the correlation between health literacy and patient outcomes. And now we're talking about how to overcome some communication challenges, and we're exploring going away from some of these medical terms. Could you get a little conversation started on the importance of using clinical and medical terms and what effects that has on the overall patient outcome?
Oh, absolutely. So we are the plain language choir, me and my colleagues, right? So we're telling you, always use living room language. Say it the way you would say it at home, at the kitchen table with your aunt and your grandmother and whoever, right? We say that, but there are some exceptions to that, right? And if you think about why we're communicating in the first place, it's so the patient understands what is going on with them and what they can do, what action they can take, and how they can take that action to get better or to stay well, right? That's what it's all about. And so we have to kind of step back from our rules sometimes and say, do we really need to avoid all technical and medical language? We don't. If a patient has a new diagnosis, they need to know the name of that diagnosis. And they need to know what it means, to your point, Dave. What does that mean? How do you interpret that? What does that mean to you? Because if we're going across languages, then even if we're not across languages, different things mean different things to different people, right? Someone may have never heard of diabetes, but they've heard of sugar. And so if you can connect those two things for them, they might understand what's going on with them. But very often they need to know that scientific and technical name. They're going to hear it ask of them later, right? They're going to be sitting in front of another provider who's going to say, now, have you ever been diagnosed with hypertension? And if they don't know that they have, if they've only been told high blood pressure, then that could be a problem. If they're filling out forms at a doctor's office and those forms are not going to be written in plain language and living room language, it's going to have the names of the official diagnoses, right? They need to know which ones to check. They're talking with a pharmacist who says, are you still taking that medication for your hypertension? They need to know that, yes, I have hypertension. And yes, that lisinopril is for that hypertension. So they need to know these names, right? But when we have to use the technical terms, we need to provide a plain language explanation of what those things mean. And there's been such a lot of talk today and just in our field in general about making sure patients understand so that they can take action. And so I don't want to not have time to talk about this. We don't know. We can follow all the best plain language practices in the book. We can dot every I and cross every T and do everything right in terms of plain language. But if we don't find out from them more directly whether they understood, it's just a guess. It's that checking the box that David mentioned earlier, right? Yeah, we told them everything and we told it all in plain language, so we should be good. The only way to truly know if they understood is to ask. And our team's been doing a lot of observations in health clinics and public health practices as well, and watching patient-provider communication. And what we tend to see is people say, what questions do you have for me? Is there anything I can help, explain better before you go? Often we don't know what it is that we don't know. We don't know what questions to ask. And so the teach back method is really, we consider the gold standard for assessing a patient's understanding. And there's some great online training that we could point you to, but in a nutshell, yes, you explain things in plain language, but then you invite them to teach it back to you. And you do that in a way that's not shaming, because none of us want to feel quizzed, right? So we don't want to say, now tell me, I want to make sure you understand. So tell me what I just told you. That doesn't feel awesome. So you might say instead something like, we just went over like several changes to your high blood pressure medicine. Can you tell me in your own words how you're going to change the medicine when you get home? Because I just want to make sure I explained it well. Take responsibility for that communication. Ask them to repeat it back to you. Then you can hear what their understanding is and you can fill in those blanks. But yeah, we're not seeing that terribly often.
Can I mention something
Yes,
to add to what
please.
Alison said? I love all of that, because it also means that the responsibility for making sure that your patient understood you continues to be yours. Many times as interpreters, with some providers who are not used to working with interpreters, who misunderstand the role of the interpreter, they feel like if you're in the room, that's sort of an automatic. I hope, Dave, you're not taking issue with this. I feel like we give pushback against the providers all the time.
I see exactly what you're saying. No, please.
That they feel that you are responsible for this part of the communication, when in reality it is not true. And by using the teach back method, you as a provider, through the interpreter, since you can speak directly with the patient, can ascertain that your patient understood what you explained. So it's kind of a checks and balances for everybody in the room. So I just wanted to mention that, because that comes up every so often. But you're here, so you know, they all automatically know what I'm saying. Well, not really necessarily, but.
Can I ask both of you kind of a question? What are your thoughts about this? Because I think everyone typically in that exam room, if you will, the provider and the interpreter want the same thing for the patient, right? Which is for them to understand and to go home and to do well. And so I can appreciate that as an interpreter, your kind of scope is to repeat to interpret what the provider is saying. So if a provider is maybe not doing that teach back, I mean, I think you would have to clear this with your provider and maybe have a conversation ahead of time. But I'm just throwing this out there. What if an interpreter could say to the provider, hey, we just went over a lot of information with this patient. I want to be sure that I interpreted things correctly. Do you mind if we do a quick teach back? Could I ask them to repeat back those medication changes for us so we can all make sure that we were clear? What are your thoughts on that? Like if it were, obviously you wouldn't want to spring that on your provider in the middle of a clinic visit, but if you are a member of that healthcare team, I'm just wondering, is it feasible for interpreters to have those conversations with their providers and kind of get at that ahead of time?
So I know, Dave, you had a quick comment. So why don't we turn to you and then go ahead.
I think, Alison, the comment I was going to make, kind of building off of what Prado said, I think dovetails very well with what you're saying, which is essentially, we're talking about health literacy, right? Which is essentially an assumption that there's kind of an epitome of health literacy and patients are trying to get there. One of the things that I would say is physicians and other healthcare providers are experts in certain areas, but they're not necessarily experts in kind of the culture that the patients are coming from, and definitely not the language that they're speaking. And so I think one of the things that obviously there's a lot of power distance in the room, especially depending if you're with an elder doctor, if that doctor's a male, there's certain things that can make it more difficult for you to feel as an interpreter empowered to kind of have some of these conversations. But what I would say is an interpreter's job, and this is what I teach when I teach kind of medical students and residents, I'm one of the few classes that they have to teach them how to actually use interpreters. I teach them that interpreters are kind of the conduit to understanding overall what their patient understands and what they don't. And so if I'm looking for my interpreter to kind of tell me if there's some subtle signs that they're picking up, some unspoken kind of communication that I'm not necessarily gonna see, where they say, oh, I don't think the patient's really understanding what we're saying here, right? And that's actually useful, extremely useful feedback to me because, and if there's a suggestion of oh, do you mind if I do this to make sure that they understand? It's I'd be yes, please go nuts. I'm really looking forward to having someone who can do that type of communication to really, but I understand you have to be delicate in how you approach it because you don't want someone to feel like hierarchies are disrupted, but at the same time, I do think we do all share the same goals. And I think there would be communication strategies you'd have to develop, kind of indirect communication styles that are somewhat mitigated speech, so that the surgeon or whoever you're working with doesn't feel like you're telling them that they did a bad job or something like that. But I really think that would be welcomed by a lot of providers.
I know you've inspired Alison to comment a little bit, and then we do want to allow Prado to also chime in.
I just wanted to, and that's what your last sentence really summed it up. I feel like you're in the choir with us, right? And you're welcoming of that and all. And so that was really my question for you is, are other providers, obviously nobody's willing for their, whole clinical scene to be taken over, but do you feel like most providers, if we can voice that shared goal and say, hey, can we talk about how we can help patients better understand and make sure they understand, you think most providers would be receptive to the conversation?
I think so. I think it is a little bit of a question of, and you said this before, Alison, that there's often a lot going on in a provider's mind because there's a lot of constraints that they're under. And so it's a little bit of a question of when. And so, Prado, you mentioned this as well of kind of a systems problem where you kind of walked into a situation where there was a huge communication issue. If the interpreter knows in advance that they're somewhat expecting there to be some challenges here, that's the kind of conversation to start off with the provider almost immediately when you walk in the room, because then that helps the provider kind of get a sense of how to negotiate their time. If the provider already has their hand on the door and you're trying to figure out a way to do a teach back, right? That's when you're going to probably run into some resistance and some challenges from the provider. So and that's the kind of thing, like, hopefully you guys are all working in the same setting. I've been very lucky to kind of work with the same high quality interpreters over time and develop relationships with them. And so that's actually made it very feasible to kind of have conversations outside of the clinical space with them so that we can better prepare kind of in the future. All of these types of strategies, I think, are really useful, so that when it's game time and you're really in the room with a patient and really need to be relatively fast because you're seeing a lot of patients in succession, that's when things can go a lot more smoothly. That said, there still are strategies when you realize that, like, oh man, we got to do a 180 because there's really not an understanding here, not a shared understanding. I think there are communication strategies, but they do need to acknowledge the power differentials in the room. Otherwise, they can backfire.
Right. Thank you for that. Thank you both. And actually, I know, Prado, you're dying to say something, but you've mentioned before having the strong partnership with the providers, and you've also mentioned this time constraints, which is something that Dave just brought up again. We do have a participant that has said, how do you even implement this when the providers are having to jump from one patient to the next, right? You have this time. So, Prado, I wonder if you can maybe share a little bit about your experiences and maybe address that as well.
I so appreciate what you just said, Dave, because I feel like a lot of providers would welcome that kind of intervention. And I use this word very, very carefully, because also interpreters we're getting trained for being, and a participant mentioned it, we're just conduits. We really don't advocate. And there's different schools of thought about even advocacy, I believe. And I think there's a little bit of a push to expand the role of the interpreter. And I even have modified that thinking myself. I do believe that in systems like these, the interpreters could have a little bit of an expanded role. It's just that giving carte blanche to interpreters for that expanded role requires experience. I think it requires a reading of the room that not everybody might be able to do right off the bat. I know I wouldn't have been able to do it successfully 20 years ago. I feel like maybe I can navigate it a little bit better now. I think there would be a way to your point, Alison, to do what you suggested. But I do believe that there should be a better understanding among the provider community, which is a humongous phrase, of really what the role of the interpreter is in the room. And I feel that there's still a segment who doesn't really even understand what an interpreter is, what we do in the room, why is this person here? And there's so many ways to provide interpretation in this world right now. I know that when I'm speaking about my experience in the hospital, it's such a small percentage of what goes on. I'm sure there's colleagues listening to me right now going, lady, what are you talking about? That is not my experience at all. And I want to acknowledge that, because not everybody has that luxury of working perhaps in a system that allows you to have pre-sessions or conversations with the provider ahead of time to plan for that particular encounter. When you peek into the room and there's 10 family members, I leave immediately and go find my provider. There are 10 family members in the room. How are we going to do this? And that's sort of the partnership. Can I do it with every provider I work with? I can't say that I can. Can I do it with a lot of them? Yes, we can. So there's just a lot here. I'm gonna leave it at that.
Any other comments on this topic before we return to the concept of plain language and technical language?
I do want to add one thing, which is you're not going to, I think a lot of doctors do recognize that there's a gap in our education, particularly when it comes to communication. And I think one of the things that interpreters can do is, in those moments outside of clinical spaces, provide a little bit of that education, right? This is, to a degree, organizational health literacy, right? Making sure that we're all on the same page about what a patient needs to get there. And I'll give an example. There is a widely known kind of group that teaches communication, specifically around end-of-life issues. And one of the approaches that they teach doctors, they essentially teach a one-size-fits-all approach to communication. And I'm saying this doesn't matter what language you speak. They teach the approach that you should essentially start with a headline, and then from the headline kind of build from that, because the idea is to make sure that everyone is on the same page. The problem is, if you start with a headline like "your dad has cancer," that sometimes immediately alienates some cultural groups that generally don't like to speak so directly, right? And I think one of the challenges of this is, like, yes, it's great that there are initiatives that are trying to teach physicians how to communicate. But I think one of the challenges is that like the physicians that have then taken these courses, they feel empowered as excellent communicators without realizing the gaps that exist, especially when it comes to cultural humility, right?
Yeah.
And so I think this is where interpreters can say, like, you can do the feedback sandwich of like, you did a fantastic job on X, but I noticed that this might have been in my culture, right? Like say, like as when I interpret the cultures that I work with, like bring your expertise into the room, which I think is really important. And I think a lot of doctors, especially ones that have taken those courses, are doing it because they're trying to improve on their skills. And I think, that then I think you can kind of augment that. But I think that the key is recognizing that there still needs to be a certain amount of education towards organizational health literacy that I don't necessarily think is really a conscious thing that a lot of providers are thinking about.
And I think that's a great way to pivot back to this conversation about the plain or accessible or kitchen language and technical language and how much of it to use in our encounter. So Alison, you introduced the topic earlier. There was actually a comment that came in right as you were discussing it. And, is there really a need to use high register almost and technical terminology such as bowel movements? And did you move your bowels? And that's one of the very common things that we encounter in healthcare settings. Tell us a little bit more about, okay, where is that line? Where do we plain and when do we technical?
So I was hoping that nobody would ask about pee and poop, but you've done it. So it's one of those things for me that I don't have a great answer about, right? I'm going to be honest, and my colleague on the call is probably laughing right now because we have had, and we do in our office, we rewrite health content for plain language all day, every day. And so very often we're saying, oh, I've never seen this one before. What do we say about this? How do we define this in a plain language way? And so when some of those topics come up, some people in our group will write, bowel movement in parentheses, poop on a paper. And I detest it. I don't like it. That's just me, because we have to walk this line. We don't ever want our content to feel too elementary, right? And so we have to walk this fine line. But our general rule of thumb is when in doubt, put it in front of people, right? And if you put it in front of 5 people, you're going to get those 5 people's opinions, unless you're going to do a long drawn out research study on this. You just have to go with what you can get. But a best practice is put your best plain language foot forward, put that document in front of community members. And we do this all the time through our community field testing process. And be careful who you invite. Let me say something about that too. Very often with these sessions, we tend to easily recruit the retired nurses and social workers and interpreters of the world, right? Who will tell you, this is great, but you really need to add another section about this really highly technical thing. And who we need at the table are some different voices. And so in our health system, we actually screen at the patient level. We have a health literacy screening that's asked in all of our ambulatory settings. And so we are able to kind of recruit community field testing participants from that group. So we get people that have some, pretty likely challenges with health literacy to sit around our tables and say, yes, this makes perfect sense to me. Yes, this is understandable. Yes, I know exactly what to do when I read this. And so again, that the ultimate goal is that people can understand. And if we have to use the word P so that people can understand, then I guess I'm okay with using it. But I don't think there's a solid answer on that. I don't think we have a ton of evidence, again, other than what we get from our community members, and that's what guides our work.
Dave, earlier you brought up anatomy and how some elements of anatomy could be uncomfortable in some cultures. So same question to you. We're talking plain versus technical language as we're trying to be accommodating, but also recognize the importance of using technical terms. What are your thoughts?
I think Alison brought up a great point in the sense that like there is a little bit of a difference between kind of spoken and written. For example, when I'm writing in English, I almost never use the word get, right? Like, do you get me? Or like, right? So even in English, we have kind of a difference in register between spoken and written. And those differences are heightened in other languages. So in Arabic, for example, it's one of the languages where it's like essentially written language is close to Shakespearean versus kind of the spoken language is a much more kind of vernacular dialect. And so when I'm speaking, I meet patients where they're at. So like if someone says there's snot coming up my boo, then I'm going to refer to their boo, because that is they are very clearly, that is what, like if I use a different term, then I'm just essentially separating myself from them. But if I'm doing something written, like when they go home, right, like then I'm making sure that we have kind of a shared understanding of vocabulary. So things that are written down, because they're not necessarily the only ones that are going to read that, right? Like their care providers, their children, like various different people, or when they go to their next, care provider, like a physician or someone else, I need to make sure that the language is specific enough that everyone understands what we're talking about. So I need to adapt to those specific contexts, but also recognize that if I put something written down, then it does have a life beyond kind of the just my interaction with the patient, and so I need to be cognizant of the other audiences that might be participating in it.
Absolutely. And now, Prado, now that you've heard these two experts talk about kind of their thoughts, when it comes to interpreters and translators, we're told oftentimes that we don't have control, and sometimes we're told that we do have control. And there's this whole debate about whether or not we intervene to lower or heighten register, and sometimes even matching register is impossible. So tell us a little bit about that. Bring us into the world of language and kind of give us more thoughts on plain language, technical language, and where do we fit in?
So when Alison was talking about, looking at documents where they mention the word poop. I mean, I've seen this on our patient education materials. And frankly, when you translate into Spanish, I refuse. I'm sorry. There's probably translators out there who would want to throw tomatoes at me right now. We just don't write that way in Spanish. There's also a certain expectation of how medical materials should sound. And I don't mean they have to sound high register, so inaccessible in terms of vocabulary. They have to sound precise. They have to be clear. But I don't think that, that lower register, colloquial register, I should say, necessarily belongs on a document. But I think Alison makes a really good point. Perhaps for certain populations or for certain documents for a certain context, that's true. Perhaps the word poop and then the equivalent in Spanish, I'm sure there's 17 varieties of poop in different regional varieties of Spanish. We won't go through them. I think there's an expectation from the patient's perspective as well. I also, and I'm mixing a little bit topics, I work in a language department where translators don't interpret and interpreters don't translate. The skill set is separated out. And so when the interpreters go to a room to interpret discharge instructions, they're bringing, the patient already has the translated discharge instructions. So I always tell the interpreters in the team, it's important that we match the verbal to the written to the extent possible. So when you're interpreting, you're doing your job. But if you have an opportunity to match vocabulary for when the patient goes home, that now they're reviewing the translated instructions, and perhaps on the instructions they're talking about tomografía computarizada rather than the CT scan that is coming up in verbal communication. So clearly I've gone into 30 directions. I also feel that perhaps translators and interpreters share a little bit of an educator role. Can we not use technical and simple language? And this has already been touched on by, I think, both Dave and Alison, so that when the patient goes to another institution and the documents have been written in a different way, they can still understand that high blood pressure and hypertension actually mean the same thing, that we're not using such disparate vocabulary that patients don't really know what we're talking to them about. I'm not sure if that answered your question, but.
I think it did. And I think Dave has a couple of comments he wants to add. Go ahead.
Yeah, I just want to add kind of a wrinkle of complexity, because we're talking about little bit related to kind of the challenge of living room language versus vulgar language. But I think there's also some challenges, and I'd be interested in perspectives, Prado, Alison, if you have perspectives on this, of between living room language and medical language. Because in Arabic, one of the big challenges is Syria is the only country in the Middle East in which medical instruction happens in Arabic. And so, when I have studied it, Arabic's not my native language, but I've studied Arabic. And so I know a lot of Arabic terms that are medical, things like nystagmus or atelectasis, things like this that appear that, physicians or other medical professionals might say, or that sometimes even appear when you do something like Google Translate. But since medical education happens in either French or English in almost every other Arab country, one of the challenges, even other physicians won't necessarily understand kind of medical language in Arabic. So I'm wondering if this is a little bit of kind of a product of colonialism, right? And one of the challenges that I see is it adds difficulty to even trying to be very specific in the communication that we're trying to do, and it adds to kind of a certain layer of complexity when we're trying to communicate, even sometimes between providers, but also with patients themselves. And I don't know if this is something that appears in other languages as well.
I think that it would apply. I think that it would apply to many languages, and even languages that have different variants of the language as well, right? I think it's something that's very applicable, or even languages that are so widely spoken in the US, such as Spanish, and it kind of takes us back to the example that Prado just shared with the CT scan. Some patients may be used to hearing the English term for something when there is a Spanish translation, which if they were receiving healthcare in their country, that's what they would hear. And the role that we play as interpreters and translators in introducing them or not introducing those terms. So we have about 15 minutes left, and I think people are interested in a lot of the different challenges that we've brought up, and maybe what are some potential solutions? What are some things that healthcare organizations can do? There's actually one of our participants here that, as we were talking about health materials, health education materials that are out there, would having a repository of educational materials that can be used by multiple health systems have a collaborative effort? Is that even something that should be explored? What are some other ideas that we have in terms of health literacy, and specifically these culturally and linguistically diverse populations that we can present to our participants here today to take back to their healthcare systems, to their teams, and maybe start to implement? Alison, why don't we give you the floor first?
Sure. I'm going to drop something in the chat from the Agency for Healthcare Research and Quality. And it's called the 10 Attributes of a Health Literate Healthcare Organization. And I think it's just a really nice framework if you're thinking to yourself, we do need to do a better job of equitably enabling our patients or community members to find, understand, and use health information. How the heck do you get started with that? I think it provides a really nice framework. And talks about the different layers that you could start with, right? And in our work, we do a lot of assessing of these 10 attributes with health systems, and everyone's low-hanging fruit is different than the next systems, right? And so it may be educating leadership about how health literacy and special language services relate to the quadruple aim or other priorities that they care about. Some organizations feel like workforce development at other layers of their organization is the attribute where they need some attention, because to David's point, their healthcare providers get a lot of training about communication. And I'll use our own shop as an example, where we have colleges of medicine, nursing, pharmacy, public health. When we talk with our faculty and we ask, I know you're doing communication training, tell us about that. There's a lot that happens in the classroom, but not as much that happens in a simulated learning environment where students can practice and get feedback on the communication. We just did an assessment. We'll be publishing that soon, looking at the literature as well as our own organization. And the simulated patient-provider communication training that happens tends to be on topics like delivering bad news, or, and really to focus on the relational aspects of communication. So developing rapport, communicating with respect and with sympathy when needed. And those are all incredibly important skills. What we see missing are those instructional communication skills, right? So how do you decide what to tell a patient? And this is kind of the framework I would give you if you're thinking about your own communication. You start with the what. What do we need to tell our patient? What's nice to know versus need to know? And then from there, it's how do you say it, right? And so we've been talking a lot about language choice and jargon, but Prado mentioned something earlier that I want to pick back up on, and It's the organization of content, right? So once we know what to say, before we even figure out how to say it, let's put it in a good order. And I know people will often question us on this and challenge us and say, well, you can't plan ahead, for every conversation that you have. No. But if you're going to explain, what to expect from an STD test, if you're going to explain that 4 times a day, you can come up with a little cheat sheet, a little outline of the key points that you want to say as you provide that patient education. And then think about your language and think about blending that plain language with that technical language. Again, what does the patient need to know? They don't ever need to know that technical language, then let's just leave it out. But if they might, then let's do that, but let's connect it to the words that they understand. So I'll stop there.
Thank you so much. Dave, why don't you share your thoughts on some of the things that we can do and healthcare organizations can do? I know it's a big part of the work you do.
Yeah, so Gabriela, I'm gonna shape that question just a little bit to build off of what Alison said. Not in terms of kind of what we can do, because I think there's a ton that we can do, but what I think is going to happen, right? And I'm not necessarily saying this is a solution, but I'm going to put in the chat kind of a paper that's been making shockwaves through at least the physician community. And it's a paper that shows, it compares real physicians versus Chat GPT in terms of providing information for patients. And Chat GPT does better. And I think this is something that we need to consider here. So, I mean, this is, if you read the paper, you can see that, there's a lot of things that we can talk about. These were questions on Reddit, right? So these are physicians that are just volunteering their time to answer questions on Reddit. So they're not necessarily putting a ton of effort into it necessarily, but on average, Chat GPT seem to kind of be higher rated. And as long as they're accurate, so this is one of the things that I would say is this is a solution that is coming. In fact, it's here, right? And so I think this is one of these things that internal medicine physicians, I think our kind of community of communicators to patients needs to think about this and recognize kind of the impact that this is going to have coming down the line and be prepared for it.
Thank you so much. Prado, same question to you. Maybe some of the things that you're already implementing within your system.
Yeah, I mean, I think if the institution supports a strong language services department, and I say this very intentionally because we all know what's happening in hospitals, they're closing interpreter departments right and left. Perhaps consider reinstating your former interpreter department if you closed it, and then invite those individuals to the table. They are your language experts, and they are to some extent, your health literacy experts. If we decide as institutions that we can get by, that if there's an understanding that patients sort of get by because they have a child or a cousin or a family member who can help them with their English in the same way that they're helping them with their digital access to patient portals, which is something that I wanted to mention many minutes ago. Then we're not doing anything for our patients. We are not doing anything for health literacy either. So from my perspective, which is probably a little narrower, is to bring the experts up invite the experts to the table, not decide that perhaps what is this thing called? This chatbot is also going to start translating informed consent for your institution. I have heard this, by the way. Please, not quite yet. Yeah, those would be my solutions. And then within the internal communication channels of institutions, there's also a lot of information that could be disseminated also to the patients. If you have a newsletter that goes to patients, perhaps there's articles about health literacy to try to empower the patients to be advocates for themselves as well. So they can break down that cultural barrier of the figure of authority that I cannot possibly challenge by asking questions or by questioning the physician. I think there's a lot of internal communication to patients that can be instituted as well.
Excellent thoughts from everyone. Thank you so much. You have truly been a panel of experts. Now we only have a couple of minutes left, and you have shared so much information that if there's one takeaway that you want participants to take from each and every one of you, that means a total of 3 takeaways. So each of you will pick one takeaway. We'll have a total of 3 things that we can take home for to our institutions, whether we're language program managers at hospitals, interpreters and translators ourselves, or other health administrators, what is that one takeaway that you think participants would take most value from? And Dave, we'll give you the word first.
I would just say essentially that we, if we can remember that we all share the same goal, which is ultimately, not just health literacy, but ultimately just like trying to improve the health of the patients that we work with. I think that's often a key thing that's helpful to kind of almost remind ourselves as a starting point when sometimes it feels like we've got a lot of competing priorities.
Absolutely. I would agree 100%. Alison, what are your thoughts?
I think my one takeaway would be assess, don't assume. And that's got some layers. I know we talked about teach back, but also at that organizational level, right? So take your written materials and use formal tools that are out there to assess the plain language qualities. Put them in front of community field testing sessions to get feedback from the people that you serve. Formally assess your written communication. Do the same with verbal. There are checklists out there from AHRQ and others that will help you assess your providers. It could be a peer evaluation thing, Don't just assume that you're communicating well in the moment or more broadly as an organization. Do some formal assessment.
Thank you. And Prado?
How do I follow that? Invite your language experts to the table. They are, to Dave's point earlier, they are your language experts. They might not know medicine, they might not know research, they might not know pharmaceutical products, but they do know language and culture. So invite them to the table, ask them, partner with them.
Excellent, excellent, excellent points. Thank you so much for joining us on this panel. Again, this has been NCIHC On The Road, and we've been exploring language and health literacy, how to speak and write for a diverse patient population. Dr. David Scales, Prado Antolino, Alison, Caballero, thank you so much for joining us today. We have thoroughly enjoyed. I don't know if you're watching the chat, but everybody is so grateful. You have provided a lot of great advice. And I would say that my biggest takeaway is that health literacy is not that easy. It's very complicated. There's a lot of levels and layers to it. And ultimately, it's about how people are able to make informed decisions about their care by knowing what is going on. And I think that we all play a big role in that, especially for our culturally and linguistically diverse populations. And the more aware and informed that we are about health literacy and its role in patient care, the better prepared we're going to be able to meet the needs of the patient. Thank you all so much.
Thank you, Gabriela. It was an honor to be here and very much appreciated your moderating. Thank you so much.
Thank you very much. Bye-bye.
Thank you.